speaker is Dr.Krishna Seshadri. He is a very popular man. He was the star performer of yesterday's Lipton Symposium, and he is currently the professor of internal medicine and endocrinology, diabetes and metabolism, Sri Rajamahindra University, and head of the Department of Endocrinology and Diabetes at the University and its medical center. He will be speaking on the consequences of tampering with the nature and how he invited diabetes. Over to Dr. Krishna Seshadri.
Good morning. I started yesterday by saying I feel like a planet in the midst of a star constellation. I need to alter that today to say I feel like an asteroid in this entire constellation because of the amazing amount of work that Dr. Mohan presented. I was sitting in the first row and enjoying the passion that he still portrays after so many years of work. And I did not notice. I have not noticed the patriotic streak in Dr. Mohan, which was very amply evident today, and I guess his passion with patriotism is what makes his work so unique. And it's interesting that he spoke about affluenza as the disease of Asians leading to diabetes, and what this entire talk is about exploring that affluenza a little further, and hopefully, this could be the start of something that we can look at in terms of research. Thankfully, for the first time, I have no conflicts of interest in this talk. But I do have a few acknowledgements. First, my research team that pretty much did most of the work that I present here, and I just come and take credit for it. And two of my major funders, one is the RSSDI and the Endocrine Society of India. Let's start with something Dr. Mohan talked about, and that is, what do genetic studies test us? Are our genes programming diabetes? If you look at the GWAS studies, you will realize that none of the genes that have been found in all the GWAS studies, except maybe PPAR, program for insulin resistance. You will find that these are genes that are cell cycle regulators, that are growth regulators, that are beta cell function regulators, but not a single gene programs insulin resistance. So clearly, insulin resistance that leads to some sort of diabetes, we need to ask two questions. One, is insulin resistance a protective phenomenon, a reactive phenomenon to some other injury? Or is it that insulin resistance is probably a part of the larger picture of epigenetic changes? But before that, let me make a statement of fact that what is diabetes? Yesterday we talked about diabetes as having less insulin, more glucagon or something like that. But really the correct answer, what is type 2 diabetes? Type 2 diabetes is an inflammatory disease. It's a disease of inflammation, and evolutionarily it makes sense. As human beings, we evolved from unicellular organisms that had three major issues. One is to create energy. Second is to respond to light and stimuli. And third, to attack back if attacked. The body's only major defense phenomenon is inflammation. If you attack it acutely, it responds acutely. If you attack it chronically, it does a low-grade gorilla attack. This is exactly what happens in diabetes. That ultimately, you can call it by all sorts of names, but diabetes is an inflammatory disease. The reaction of the body is inflammation. All the other stuff that we see are the collateral damage that occurs because of inflammation. And this is the first time that they showed in human pancreatic islet cells that inflammation actually occurs. But let's take this forward. Just to sort of touch on epigenetics, it's a heritable change in gene function that can occur without a change in nucleotide changes. Which means that diabetes is because of three things. One is the genes, not too much. Changes that occur around the genes, then what the environment does to it. So that brings us to the big environmental picture. There are 6 things that we have done to nature more in the last 100 years. First thing is food. The second thing is light and sleep. The third is technology. The fourth is a flat world with no distinction between time zones. The fifth is stress. The sixth is lack of sunlight. talk about this. We eat more than we have ever before. We eat at the most odd of times. Our food quality has changed, and Dr. Mohan talked about this. I always say that we are the only species that eats food for entertainment. Every other species in the world eats because it needs food. We kill and eat for entertainment. We have less light. We were having this discussion this morning that we have more light extending longer and longer in the day than nature intended, and I'll talk about this. We have less physical work. We have more stress and no downtime, and of course less sunlight. And I'll talk about some of this and some of the work that we've done. So let's start with food, because that's something that we all like, isn't it? The interesting thing is that every time you have a high caloric meal, that includes the breakfast that I had today, there is a certain it has been demonstrated that if you eat a little out of the ordinary, there is a neutrophilic infiltrate that occurs in your abdomen. This has been well documented. But what happens when you keep doing it over and over again? In nature, we are not used to this amount of food. Nature has always been trying to conserve food. That is why, the SGLT2 inhibitors are a unique concept when we talked about it, because you have so much to take away the glucose back. The body tries to retain energy. So when you give it a lot of food, it says, like my grandmom who put all the extra change in her rice box, the body says, let me save it for a rainy day in your belly. And your adipocyte size starts increasing. Now we now well know that as the adipocyte size increases, your risk of diabetes increases. But remember that the adipocyte is the last stop to protect your body against the ill effect of fat. So what happens is, as the adipocyte size increases, at some point of time, the body senses that something abnormal is happening. And remember what I said, there is only one way that the body knows how to respond. If it senses a threat, it responds with inflammation. So as the adipocyte size increases, the signal is sent to the macrophages in the bone marrow saying, hey, something's wrong happening in the abdomen. And so there is a migration of CD2 positive macrophages. When these macrophages come into the abdomen, they change. They undergo what is called a phenotypic switch. From helper cells that are supposed to come into these into the abdomen, they start becoming killer cells. And then something very unique happens. These macrophages start joining with these adipocytes, and they form a jugalbandi. It's like having two twins in a china shop. Guess what will happen at the end of it? It's all broken. I'll show you an example. This is a protective hormone made by the adipocyte called the adiponectin. This is GLUT4, which is used to transport glucose. Now, when you put them together, see what happens. At the baseline, the adiponectin is 127. After 12 days, the adiponectin has already gone by half. This is GLUT4 expression, which is required to transport glucose. After 12 days, it's already gone by half. Exactly what is happening in all our bodies all the time. So, as this keeps going on, that this jugalbandi goes to a point where the adipokines are increased, the chemokines are increased, the adipocyte starts dying. There's something called an inflammasome that gets activated, the adipocyte starts dying, there is apoptosis that takes place in the adipocyte. The next thing that happens, fat becomes systemic. It goes into the liver, it causes NASH, it goes into the blood vessels, it causes atherosclerosis, it goes into the pancreas, it causes pancreatic inflammation and beta cell dysfunction. This is really what's happening in all of us at this point of time. And this is the biologic basis of diabetes, and it has an inflammatory angle. Now let's see if there's something more to this. We looked at, and Dr. A.K. Das alluded to this, we looked at this phenomenon of the teeth as being, are there other players in this whole thing? This is one of our studies that was published in the IJEM, that is accepted as an abstract, and that shows the association between periodontitis and diabetes. Remember that we start eating food with our mouth. Interestingly, the salivary MCP1 levels correlated exceptionally well with the HbA1c. When we submitted this for publication, the first question that they asked is, how come you do not have a control level where the A1C is high and there is no periodontitis? We had to write back to the reviewers saying, we could not find a single patient with an A1C of more than 8 who did not have periodontitis. And so, this is, and now what we're doing is we're trying to look at if the oral flora is changing. We're looking at next generation sequencing of Porphyromonas gingivalis to see if this is itself altered. So the kind of food that you eat actually makes a difference. And we have another study that shows that if you intervene by using scaling at least 3 times a year, your A1C actually came down, that the AOPP products came down. So really the truth is that if you brush your teeth 3 times a day, your A1C comes down with 3.3 to 0.4, which is as good as a gliptin or metformin. Don't tell that to the pharma guys outside. So if this is what's happening in your mouth, what's happening in your gut? Remember that this is like the rat and the house owner. The house owner thinks he built the house. The rat thinks that the house belongs to it. Similarly, our body is actually full of billions and billions of microorganisms which thinks that they belong to it or this belongs to it. So our gut, we inherit the microflora from our mothers. Our skin has microflora, and these are all important. Now what we do, and this microflora protects us, it coexists with us and prevents disease. If you change the food you eat like we have in the last 100 years, they change. And when they change, they cause disease. For example, when the microflora thing changes, like in our study, the first metagenomic sequencing of gut microflora in diabetics versus control in India, and you will see that the ratio of the Provotella Fusifically-bacterium ratio is changed, the Firmicutes range. You will find that in controls who do not have diabetes, the Provotella species dominates. In the diabetics, I'm sorry, the other way around, the Faecalibacterium dominates, the Provotella dominates. Interestingly, this was published in the Keystone Symposium this year, that as your BMI increases, the Provotella species actually changes. There is a shift from Firmicutes to Proteobacteria and Provotella. In patients with a higher A1C, the Proteobacteria actually dominates, which means that as the inflammation proceeds, there is a chain reaction that's occurring that is changing the bacteria. Now the question is, can you alter it? A lot of people have thought about probiotics, prebiotics. We still don't have concrete data. But the truth is that if you haven't eaten the food of your ancestors, you're setting yourself to a new environment. Change generally occurs over a period of time. What have we done? We have accelerated change. When we've accelerated change, the body doesn't find time to adapt it. It perceives it as a threat. The threat treats its inflammation, and inflammation causes diabetes. So let's move on. And this just shows the MCP1 levels as a random scatter, but it shows that the inflammation increases as the bacteria change. I talked about food. Let me talk about something else just for a short moment, and that's sunlight. We are obsessed with being fair. I mean, I know how many of you walked in Europe, you'll find all the Europeans walking on the sun, but the Indian tourists will make sure they walk under the awnings of the shops so that the sun doesn't hit them. And this is very, very Indian. I don't know, we are obsessed with being fair, while everybody in the world thinks dark and handsome is nice. We know that there is a certain association with vitamin D and diabetes. I don't want to push this too far because I think the action of vitamin D in that setting is actually that it is not a endocrine hormone, it's an intracrine or a paracrine hormone. It is more a local factor. But we know that baseline diabetes, vitamin D increases the risk of diabetes. But what we know is that at a translational level, that vitamin D is important for GLUT1 and GLUT4 action. This is our own data that has been published that shows that vitamin D increases GLUT4 expression, and if you alter vitamin D and you knock down the vitamin D receptor, you have lower GLUT4 expression. So what we now know is that there is a correlation, and it means that if you moved away from the sun, your risk of diabetes goes up. Also, vitamin D is important for the prevention of atherosclerosis because they work on adipocyte progenitors. And here what happens is your risk of diabetes goes up. So, I talked about two things. Let me talk about something that I love even more. And that if I love food more, yes, but do I love sleep more? Even more. And that's the next thing that we have played with. Why is sleep necessary? Why do you think we should sleep? Why can't we be awake? For a long time, we did not know why sleep is necessary. But now we do. This is an amazing paper. People who have not read this, please read this paper by Huzel et al. In Science that talks about why we need sleep. What happens in the night when we fall asleep is that you actually shrink your brain size by about 1/3. Which means the clefts and the spaces in between the cells and the neurons actually expand so that CSF can go down and remove the toxic stuff there. Yes, I got it. And this is the time to remove it. When you interfere with sleep, you interfere with a fundamental requirement of nature. Remember that we were all unicellular bacteria. At that point of time, light and darkness was important. Light to create food, darkness to regenerate. You increase the amount of light you have and reduce the amount of darkness you have, you play with nature. And let's see what happens quickly. Short duration of sleep increases risk of diabetes. Remember that long duration also does it. But even more important is the quality of sleep. That the way you sleep is important. The Vedas knew it, but this is what science tells you. You restrict sleep and you do a transcriptome of what happens, you will realize that the most of the genes that get expressed in sleep restriction are the same genes that cause diabetes, which are the inflammatory genes. Exceptional data. And I won't spend too much time on this, but remember that if you interfere with nature's clock, it resets every other clock in the body. And let me show you an example of what happens. This is fragmented sleep causing diabetes. This is our own data on sleep disturbance diabetes. I'm going to spend 1 minute on this. You take an animal, you look at its beta cells, and you change the light exposure in the beta cells. Instead of light, day, and dark, you move it to a light cycle. See what happens. The insulin production changes, the amount of beta cell insulin being produced changes, and if there's a predisposition for diabetes in that particular animal, beta cell apoptosis also changes. So what's happening to our young people who are working in American Standard Time? They have less sleep, they are sleeping at different times, and guess what's mucking up their beta cells? It's not just food, it's not just exercise, it's sleep. So if there's a circadian misalignment, there's an increased risk of diabetes. Rotating shift nurses, especially people who work on rotating shifts, increase risk of diabetes. But even more important is we are also larks or owls. I am brightest at 4:30 in the morning. At 10 o'clock in the night, you can't beat me to say a good word. And if you take someone who's a lark, which is a chronotype of who you are, and make you go on a night shift and say you work for American Standard Time, guess what's going to happen? Risk of diabetes increases. That's why, the Ratri Suktam is there. It's that Sano Adhyayasya Vayam Yavan Vikshamahi Vrikshena Vasantim Vaya. So embrace sleep, because sleep is like a tree that lets the birds rest in it for a night. And that's really what sleep is important for. Lastly, of course, stress. I won't spend time on it. Stress increases the risk of, there is an increased risk of insulin resistance. There's data that now shows that yoga increases diabetes outcomes. But this is my story. The story is that we've played with nature. We eat at the wrong times, we eat food for entertainment, we eat more than we need to, we don't give away the food that we have to. 100 years ago in this country, there were no hotels because it was thought it was a sin to sell food. You could go into somebody's house and have their simple food that they ate. We don't do hard work. In our bedrooms, the televisions and iPads have invaded so that people don't talk to each other. We sleep much shorter. Lights, there's been data that shows that the LED light of your iPad can actually reduce your sleep quality. So this is what we have done. And to add to all the things that Dr. Mohan said, I think it's time to start at least pulling back some. The big question for the big planners here is the economic development that our country is undergoing worth the healthcare price that we are paying? Which means, is there going to be a generation of healthy people that is going to enjoy all these stuff that we have gained in the last 20 years? On that thought, and we plea not to play with nature too much, thank you for your patience listening. I hope this was useful for you.
And that was a wonderful presentation. Thank you, Dr. Krishna Seshadri. And we are running short of time, and one question can be allowed.
Yes.
Any studies on inflammatory markers like TNF and interleukins? On diabetes?
Absolutely. All the data is there on MCP1, interleukin 6. In fact, today you can use
Is there anything done to fight against that?
Yes, today you can use an anti-inflammatory. I didn't want to talk about it, but you can use an anti-inflammatory to treat diabetes. There's data by Alison Goldfein that looks at salicylates in treatment of diabetes. Evidence-based. Hydroxychloroquine that has been used. It's been approved in India to treat diabetes. I don't know how they got it so quickly, but yes. So you can treat inflammation, but why don't we treat the cause?
Did you have one question about quality of sleep? You were actually fast, so I didn't read that thing. Did you have anything from quality of sleep to the diabetes? My question is from the point of view of top class politicians. We know Indira Gandhi or like Modi, and they sleep very less and they are more energetic.
Their political DNA is different, sir. Thank you so much.